Hello everyone. Today we will talk about wide complex tachycardias. Wide complex tachycardias include VT and supraventricular tachycardias with epidency. They both possess difficulty in interpretation because of the resemblance they present on ECG and is a topic of great concern for all, especially for young graduates. The normal cardiac pathway includes a network of specialized tissues that stimulate contraction. It consists of modified cardiac myocytes. The heart can contract without any innervation. Uh, in the beginning, the SA node generates the first impulse. It is then transferred to both atria where different internodal pathways from where it goes into the atrioventricular node, and from atrioventricular node it takes the bundle of His which divide into right and left bundle branches, and then subsequently all of the ventricular muscular walls are depolarized. Now, these tachycardias can be divided into two basic types. These can be normal narrow complex tachycardias or wide complex tachycardias. In narrow complex tachycardias, um, the QRS complex is of less than 120 milliseconds, which means that when we divide it into small number of small squares that you see on the ECG plate, they are usually less than 3 small squares. That makes it less than 100 milliseconds. A narrow complex tachycardia reflects the rapid activation of the ventricles with the normal hyperkinetic system, which in turn suggests that the arrhythmia originates above or within the atrioventricular node. That is, it is a supraventricular tachycardia. Whereas usually a widened QRS complex, which is more than or equal to 120 milliseconds or more than 3 small squares on an ECG graph, occurs when the ventricular activation is abnormal. It can be abnormal because of the many reasons. It is basically a slow conduction pathway. The arrhythmia originates outside of the normal conduction system, and it is usually below the AV node. Abnormalities within the hyperkinetic system can cause this. Arrhythmia originating below the AV node can cause this, and there are certain pre-excitation syndromes in which an SVT is conducted to an intergradely to an accessory pathway, resulting in the direct activation of the ventricular myocardium. Now coming towards the diagnosis. Diagnosing the arrhythmias is difficult. It is although most of the wide complex tachycardias are due to ventricular tachycardias, however, the differential diagnosis is must. Different algorithms have been defined to identify the exact etiology, but these algorithms are still very complex and are imperfect. Most of the time, urgent therapy is required. Patients may be unstable at the onset of arrhythmia and deteriorate rapidly at any time, particularly if the wide complex tachycardia is a supraventricular tachycardia or a supraventricular tachycardia with a rate of more than 200. The first priority is patient stability. Unstable patients should be treated immediately before an extensive diagnostic evaluation, whereas stable patients with ECGs that can be thoroughly read and systemically reviewed later. Now, coming to the diagnosis. In most patients, a probable diagnosis of the ventricular tachycardia or supraventricular tachycardia can be done by closely reviewing the ECG. Although the definitive diagnosis is not always possible, we may need different electrophysiological studies for that, but we can make 90 to 95% QC guess that the tachycardia is supraventricular or ventricular. For optimal ECG analysis, both a 12-lead ECG and a rhythm should be obtained. And the most important thing, comparison with a previous or baseline ECG can be very helpful in these patients. Patients with aberrant conduction at baseline will virtually always have an aberrant conduction during supraventricular tachycardia that we can easily identify when we have a previous ECG available. Now let's start discussing the important points regarding supraventricular tachycardia. There are different types. Whenever we look at ECG, we look at the rate and the rhythm indexes and all these things. These things, we will go through these things in the start, and then we will try to study some of the algorithms that have been defined to identify the supraventricular tachycardia and to differentiate it from ventricular tachycardias. Now coming towards the heart rate. Heart rate is not of so much use determining whether the tachycardia is a ventricular tachycardia or a supraventricular tachycardia. It has a very limited use in distinguishing it. When the rate is approximately 150 beats per minute, we can consider atrial flutter with let's say a 2 to 1 block and aberrant conduction that can be considered when the heart is around 150 beats per minute. Although this diagnosis should not be accepted without any supporting evidence. As you can see in the picture, there is a atrial flutter with a one-to-one conduction, but we cannot readily identify the one-to-one flutter waves in this. The patient was given adenosine, and adenosine uncovered the flutter waves, which can be seen in the ECG shown below. Once again, adenosine was given to the patient, but we had to be sure first that it is not a VT. After rate, the next thing is the rhythm. In VT, the rhythm is generally regular. All there are slight variations in R interval, which are sometimes seen, and it also suggests VT, as opposed to most SVTs, in which the R intervals are not. There's not so much variation in the R intervals. There is a uniformity in SVTs, in RR intervals due to SVTs. When the onset of arrhythmia is available for analysis, there is a period of some irregularity and acceleration which suggests VT. This phenomena is called warm-up phenomena. Like you can see in this picture, there is some irregularity that you can see before the initiation of the rhythm, and hence it can give us an idea that the rhythm is a VT rhythm. However, more marked irregularities of R interval also occur in polymorphic VT and atrial fibrillation with aberrant conductions. Coming to the third important characters we can find in ECG are the axis. Now, as we know, we can determine the complex. We can, by looking at the complexes in the limb leads, we can identify the axis of any ECG strip, any ECG rhythm. If the QRS complex is upright or positive in both lead 1 and lead AVF, this is the normal axis, which is usually between 0 degrees centigrade, 0 degrees and 90 degrees. If the QRS complex is upright in lead 1, like in this picture, shown in this picture, and downward in lead AVF, then the axis is between 0 degree and minus 90 degree. To further distinguish normal from left axis deviation in this setting, we have to look at lead 2. If the lead 2 is downward negative, then the axis is more towards 120 degree minus and left axis deviation is present. If the QRS complex in lead 2 is upright or it is positive, then the axis is more towards plus 60 degrees centigrade, and it shows that the QRS is normal. If the QRS is predominantly negative in lead 1 and positive in lead AVF, then the axis deviation is right axis deviation. This is the normal axis deviation that we calculate in normal ECGs or in any ECG presenting in our ERs or anywhere. In case of VTs, what we can usually see is a right superior axis deviation, which is also called an extreme axis deviation or indeterminate axis or northwest axis. It is very rarely seen in SVT and strongly suggests a VT. The QRS is downward, like you can see in this picture. The QRS is downward, negative in lead 1, and downward in lead AVF. Then this axis is called indeterminate and sometimes referred to as northwest axis. This finding is uncommon and usually comes from a ventricular rhythm. However, it can also be from paced rhythms. Lead misplacement can also lead to such images, and certain congenital heart disease can also cause this. There are, however, two exceptions to this rule. The first is an antidomic reentrant tachycardia, which is seen with ventricular excitation. In this situation, there is a direct activation of the ventricular myocardium bypassing the normal His-Purkinje system, and the QRS complexes may have an indeterminate axis. The second is a biventricular pacemaker, in which the axes are often indeterminate with an initial Q wave in lead 1. Compared with axis during sinus rhythm, when an old ECG is available for review, and excess shift during the wide complex tachycardia of more than 40 degrees suggests VT. In a patient with right bundle branch block like wide complex tachycardia, a QRS complex excess to the left of more than 30 degrees suggests a VT, whereas in a patient with left bundle branch block, a QRS excess of right of more than 90 degrees suggests a ventricular tachycardia. Another important thing that we need to see in an ECG with wide complex tachycardias is the QRS duration. By definition, the QRS definition is at least 120 milliseconds in a wide complex tachycardia. In general, wider QRX favors VT, whereas a shorter QRX goes more in the favor of SVT. If there's an RBB like wide complex tachycardia and the QRS duration is more than 140 milliseconds, it suggests a VT. Whereas if the wide complex tachycardia is more like an LBB, but the QS complex duration is more than 160 milliseconds, it suggests a VT. There are several studies which have measured the QS duration in VTs, and they have found that if the QS duration is more than 160 milliseconds, it is a strong predictor of a ventricular tachycardia. However, a QS duration of more than 160 milliseconds is not helpful in some settings, including SVT with an accessory pathway in presence of drugs which are capable of slowing interventricular conductions, such as class 1 antiarrhythmic drugs, and hyperkalemia can also induce these changes. A very wide QRS complex may also be seen with dilated cardiomyopathy, in which the diffuse fibrosis may produce a marked slowing of impulse conduction through the ventricular myocardium. Apart from that, a QS duration of less than 140 milliseconds does not exclude a VT, since VT originating from the septum or within the his Purkinje system may be associated with a relatively narrow QRS complex. Another thing that we need to consider is the concordance. Concordance is present when the QS complex is in all 6 precordial leads, that is from V1 through V6, are monophasic with the same polarity. Like you can see in these two images, the QS complexes are all in the same direction. All are up in the picture on your right, and all are downwards in the picture on your left. When present, concordance is frequently associated with VT, but by itself is not a diagnostic for VT. If any of the 6 leads has a biphasic QRS, like a small q and large R or RS complex, concordance is not present. Positive concordance, that is V1 through V6, are entirely positive with tall monophasic R waves. It is most often due to VT, but can also occur in relatively rare cases of antidromic AVRT with a left posterior accessory pathway. Negative concordance, like you can see in this picture, that is V1 to V3, are entirely negative with deep monophasic QRS complexes, is strongly suggestive of VT, but it is also not definitive. Rarely, supraventricular tachycardias with the left bundle branch block aberrancy will demonstrate negative concordance, but there is almost always some evidence of an R wave in the lateral precordial leads in those cases. Where the presence of concordance strongly suggests VT, that is having a more than 90% specificity, its absence is not helpful in diagnostic. Approximately its sensitivity is around 20%. Okay, another characteristic is AV dissociation. Whenever AV dissociation is identified on ECG, it largely establishes the diagnosis of VT. It cannot be seen in every case of VT, but whenever it is seen, it is, you can say, a pathognomonic of ventricular tachycardia. It is characterized by atrial activity that is independent of the ventricular activity, usually with the ventricular rate exceeding the atrial rate, except in instances of a double tachycardia, for example, where there is a concurrent atrial flutter and a VT. Though not always present, fusion beats and captain beats are readily recognized indicators of AV dissociation. In a wide complex tachycardia with AV dissociation, an atrial rate slower than the ventricular rate strongly suggests VT. An atrial rate that is faster than the ventricular rate is seen with some kinds of SVTs such as atrial flutter or an atrial tachycardia with 2 to 1 AV conduction blocks associated with blocked atrial impulses. In these settings, however, there is a consistent relationship between the P waves and the QRS complexes. So this is not true AV dissociation. While AV dissociation largely establishes the diagnosis, its absence is not as helpful for two reasons. AV dissociation may be present but may not be obvious in an ECG. And number two, in some cases of VT, the ventricular impulse conducts backwards through the AV node and captures the atrium also, which is referred to as one-to-one retrograde conduction. So in fact, it is AV association rather than AV dissociation. This may be seen more commonly when the rate of VT is slow. VT with retrograde ventricular conduction or with 2 to 1 ventriculo-atrial conduction technically does not exhibit AV dissociation, though the ventricular rate exceeds the atrial rate. In all cases in which there is a retrograde VA conduction, the P waves will be inverted in the inferior rate. That is a important thing that you must keep in your mind. During a wide complex tachycardia, P waves are often difficult to identify. If the P waves are not evident on the surface ECG, direct recording of the atrial activity can reveal AV dissociation. P waves are said to be dissociated if they are not consistently coupled to the QRS complexes, which can be seen by a PP and RR intervals which are different. If the PR intervals are variable, there is no association between P and QRS complexes. The presence of a P wave with one or more, but not all QRS complexes. These also show dissociated P waves. Now, fusion or capture beats, when identified on the surface ECG in a patient with wide complex tachycardias, are diagnostic of VT. What are fusion beats? Fusion beats occur when one impulse originating from the ventricle and the second supraventricular impulse simultaneously activate the ventricular myocardium. The resulting QRS complex has a morphology intermediate between what is of a sinus beat and a pure ventricular complex. Intermittent fusion beats during a wide complex tachycardia are diagnostic of AV dissociation and therefore VT. Like you can see in this picture, this waveform is a combination of an impulse that was originated from a ventricle and a supraventricular impulse, and hence it is called a fusion beat. You can see the different morphological features of a VT wave and a fusion beat. Now, capture beats, which are also called rested beats, are QS complexes during a wide complex tachycardia that are identical to the sinus QRS complex. The term capture implies that the normal conduction system has momentarily captured control of the ventricular activity from the VT focus, like you can see in this picture. Fusion beats and captured beats are more commonly seen when the tachycardia rate is slower. Now, coming to the diagnosis. Most patients with wide complex tachycardias will have some but not all of the features that we have discussed so far. There is no single criterion or combination of criteria that provides a complete diagnostic accuracy in evaluating a wide complex tachycardia. It is typically necessary, therefore, to integrate multiple ECG findings into a diagnostic strategy. Of the several strategies that have been proposed, the Brugada criteria is most widely known and reflects the initial approach that we generally use. However, because the diagnosis of a wide complex tachycardia cannot always be made with complete certainty, even with using multiple ECG criterion, or a known or uncertain rhythm should be presumed as a VT in the absence of any contrary evidence. VT is far more common in supraventricular tachycardia by a factor of 4 in unselected population and by as much as 10-fold in patients with prior myocardial infarction. Additionally, presuming a VT guards against inappropriate and potentially dangerous therapies directed at SVT, which can precipitate hemodynamic deterioration in patients with VT. And the treatment of SVT as if it were VT is safe and frequently effective in restoring sinus rhythm. Okay, what is Brugada criteria? Brugada criteria are basically 4 different questions that help us in diagnosing a VT. What are these four questions? Whenever you see a ECG with wide complex tachycardias, you have to ask these four questions. What is the first question? Is there an absence of RS complex in all precordial leads? If you can see that there are no RS complexes in any of the precordial leads, then this is a VT. But if there is a presence of RS complex in any one of the precordial leads, then we have to ask the next question. The next question is the RS complex in any precordial lead with RS interval more than 100 milliseconds. If there's an RS interval more than 100 milliseconds, then this is a VT. But if the RS interval is not more than 100 milliseconds, it is less than 100 milliseconds, then we have to go to the third question. The third question is we have to look for an AV dissociation. If there is any AV dissociation, then yes, it is a VT. But if there is no AV dissociation, then the next question should be asked. The next question is the ECG which we have in front of us. The morphological criteria for VT is present in both leads V1 and V6. If the morphological criteria is fulfilled, then it is a VT. If it is not, then it is an SVT. We can use this Brugada criteria in all those wide complex tachycardias, and it can help us in differentiating it from supraventricular tachycardias. The next thing, Versace's approach can also be used to identify VTs. In Versace's approach, we also have to ask four questions, and after answering all those, we can reach to a definitive diagnosis. The first question we have to ask on an ECG is there any AV dissociation present? Like we have already discussed, AV dissociation is a strong predictor of VT. So if an AV dissociation is present, then we will call it VT. But if we cannot appreciate an AV dissociation, we have to look at AVR and see if there is an initial R wave present in the AVR. If there is an initial R wave present in the AVR, then this shows it is a VT. If there is no R wave in the AVR, then we have to look at the QRS morphology. If the QRS morphology is like a bundle branch block, then it is a VT. But if it's not like that, then we will have to go through the VI over VT ratio. VI over VT ratio, if it is less than or equal to 1, then it is a VT. But if it's not that, then it is a supraventricular tachycardia. What is VI and VT? VI and VRT are the magnitudes of voltage changes in the initial and terminal 40 milliseconds of the QRS. What we have to do is we have to take the magnitude of the, when we have the QRS complex in front of us, we have to see the voltage in the initial 40 milliseconds of the QRS and the voltage in the terminal part of the QRS complex. If at the 40 milliseconds time, then we have to take this ratio. Another criteria is limb lead algorithm. In limb lead algorithm, at least one of the following criteria should be met. There must be a monophasic R wave in lead AVR, or there is a predominant negative QRS complex in lead 1, 2 and 3, or there are opposing QRS complexes in limb leads, that is concordant monophasic QRS complexes in all inferior leads and concordant monophasic QRS complexes in 2 or 3 of the remaining leads with opposite polarity of the inferior leads. Along a series of 528 wide QRS complexes tachycardias, the limb lead algorithms had overall similar accuracy compared to other algorithms, with 88% versus 85% with Brugada and 88% with Versace's approach. In general, limb leads algorithms had lower sensitivity but higher specificity for diagnosing a supraventricular tachycardia. We can use Bayesian approach. It also utilizes likelihood ratios. For 6 ECG criteria, patients are presumed to start with a prior odds ratio of 4.0 in favor of VT. As each criterion is evaluated sequentially, the associated likelihood ratio is multiplied by the prior odds ratio to calculate the new probability of VT. The final odds ratio is considered consistent with VT if the value is more than 1 and SVT if the value is less than 1. We can also use intravenous adenosine, which can be administered at both as a diagnostic and potential therapeutic agent. Another important thing in this study is differentiating between VT and antidromic VT, which is particularly different because there is direct myocardial activation in both the VT and antidromic AVRT. Many of the standard criteria are not able to discriminate antidromic AVRT with VT. The predominant polarity of the QRS complex in lead V4 through V6 is defined either as positive or negative. If predominantly negative, the diagnosis of VT can be made. If the polarity of the QRS complex is predominantly positive in V4 through V6, the ECG should be examined for the presence of QR complex in one or more of the precordial leads through V2 lead V2 to V6. If the QRS complex can be identified, VT can be diagnosed. Next, if a QRS complex in lead V2 through V6 is absent, the AV relationship is then evaluated, the AV dissociation. If a one-to-one AV relationship is not present and there are more QRS complexes than P waves, VT can be diagnosed. When any of these criteria are met, VT is likely. However, if the ECG does not display any of the three morphological diagnostics of VT in this algorithm, the diagnosis of antidromic AVRT must be considered. Importantly, the QRS complex morphology and the STT waves are uniform in AVRT as every impulse to the ventricles is conducted through some accessory pathway. The Kindwell criteria of red bundle branch can also be used. According to this criteria, if initial R wave is more than 30 milliseconds in V1 or V2, it is a VT. Or the V1 or V2 QRS complex at the nadir of S wave is more than 60 milliseconds, then it is also a VT. And if there is a notch in S wave downstroke in V1 or V2, this also signifies VT. This is a summary of all that we have discussed. I hope I have made it easy for you to understand some of the differences between SVT and VT. You can go through these slides again. I will share the link below, and if you have any questions, you can post them in the comments and I'll try to answer those as well. Good luck. Thank you.